months is not significant. None of our patients was positive for hepatitis B surface antigen, while 50% were anti-HCV positive. Only 22 of them were PCR positive, which contribute to 27.5% of the studied patients. Elevated level of liver enzymes and iron parameter were present in most of our patients. As we see, ferret and increased level in ferret, 87.5% of our patients has increased level of ferritin. And transferrin saturation 80%. ALT 70%. The mean ferritin level in patients with high ALT level and high AST level were significantly increased in patients. The mean ferritin level in patients with high ALT and high AST is significantly higher as compared to those with normal ALT and normal AST. The patients were divided according to their ferritin level. We see that the iron parameter, mainly ALT and gamma GT, are higher in patients with high ferritin level as compared to those with ferritin level less than 320. As regard transferrin saturation, the mean level of liver enzymes in patients with high transferrin saturation had no significant difference as compared to those with normal transferrin saturation. This table shows that all liver enzymes and ferritin are highly significant, higher in patients with anti-HCV positive as compared to those in patients with anti-HCV negative. But only the mean of ALT and ferritin level were significantly higher in patients with HCV PCR positive as compared to those of patients with HCV PCR positive. This is a positive correlation between ALT and age in a year and a level of ALT and duration of the disease in years. Iron overload is a leading cause of elevated liver enzymes. Although the risk of transfusion-associated hepatitis has been reduced, it is still high. Presence of HCV infection is significantly related to the increased iron overload. Our results reveal significant relationship between HCV, serum ferritin, ALT level, age of the patient, and duration of blood transfusion. We recommended net for proper screening for HCV infection in donated blood, regular follow-up and screening for HCV infection for all thalassemia major patients should be done for early detection, diagnosis, and consequently early treatment. Proper patient guidance for proper compliance with iron chelation therapy. Further researches toward finding new therapies other than blood transfusion.
Thank you, Dr. Ola, for this nice presentation and highly illustrative PowerPoint. Really nice. Thank you. And now it's our pleasure to announce for the closure of this session. If there is any question, we have 2 or 3 minutes. If there is any question. No question. So it's our pleasure to announce for the closure.
Can I make a little comment? هو بس علشان هي علشان دكتور أنا صوتي عالي. Dr. Siham, it was very interesting. وعايزه اقول لحضرتك الليبيد بروفايل اليوجوال ليبيد بروفايل ده استاذ الدكتور احمد سامي خليفه 25 years ago عمل ليبيد بروفايل عيانين و at this time قالوا اوكي they do have a low level زي ما حضرتك طلعتي كده low cholesterol اللايبوبروتين باترن بتاعهم they are not كده فعلا they are not at risk of atherosclerosis. بس احنا كمان دلوقتي مش بس كراتة انتيميثيكلس لما بنعمل بقى الفول ليبيد بروفايل including الابو A والابو B والسمول لايبو A ده prove to be altered ويبقى ده برضه ممكن يكون an indicator للعيانين دول اللي عندهم atherogenic lipid profile. Thank you.
Thank you. Thank you, Dr. Alfa. If there is any questions? Any more questions? Okay. Thank you. It's our pleasure to announce the closure of this session. And now we will move to. Is there a coffee break? There is. Okay, coffee break. لا بس هم قالوا انهم عشان يخلصوا لان احنا متاخرين عن الوقت. بالتالي مفيش نسال اورجنايزنج مفيش حاجه برضه مفيش حاجه برضه. دلوقتي خلاص we will move to the last session and we will have lunch after that. So now we move to our 9th session, which is pediatric internal medicine hematology department, Cairo University, conjoined exciting case presentation, and the chairperson invited to attend. Thank you.
There are not many attendees, but this is the most session that makes people interact with the podium and interact with the speaker. And there are 4 very interesting cases that are going to be presented. 2 from the clinical hematology unit, pediatrics, Cairo University, and 2 from the clinical hematology unit, internal medicine, Cairo University. And we are going to start with Dr. Dua Al-Murdash, first case. Dr. Dua Al-Murdash, assistant lecturer, clinical hematology unit, internal medicine department, Cairo University. MSc internal medicine, MSc clinical hematology, MRCP. Please start the first case with Dua.
فين البوتنج؟ فين
لا شغال بس هو
ليه مفيش البوتنج؟
Thalassemia, 25 years old male from Upper Egypt, presented at the age of 2 years with anemic manifestation of hemolytic anemia, and who was diagnosed to be thalassemia. With his first decade of life, the patient maintained a stable hemoglobin level between 9 to 10, and he didn't receive any blood transfusion. Then, in his second decade of life, his hemoglobin level started to decrease, and the patient started blood transfusion. His demand for blood transfusion, 3 unit packed RBCs per month. At the age of 12, splenectomy was decided for the patient because severe left hypochondrial pain and also the requirement for blood transfusion. The patient maintained a stable hemoglobin level till the age of 18. Then the hemoglobin level started to decrease, and his demand was 1 unit packed RBCs per month. The patient maintained post-blood transfusion and subcutaneous iron chelation till the age of 20. Then he stopped treatment and follow-up at the age of 20 due to financial costs. He had to travel from Upper Egypt to Cairo to receive the blood transfusion and his supply of iron chelate. And 1.5 years ago, the patient had a fracture in his left foot due to minor tumor. The patient referred to our clinical hematology unit internal medicine department with an 8 months of gradual progressive paresthesia, tingling and numbness, and bilateral lower limb weakness with sphincteric discomfort. Examination revealed a young man with a body mass index of 20 and poor musculature development. The patient has the typical characteristic thalassemic features. He had a pale skin and an ecteric He had moderate hepatomegaly and his spleen was surgically removed. The patient's higher mental function and cranial nerve were normal. He has bilateral lower limb hypertonia and bilateral lower limb hyperreflexia, bilateral lower limb weakness, his power grading 0/5 in the lower limb, and also he has Brzezinski signs denoting pyramidal affection. There was complete sensory loss and also superficial reflexes were absent below level of T cells. There was tenderness over T4 vertebra. So we are facing spastic paraplegia with a sensory level in a thalassemia patient. The first voting, the differential diagnosis could be one of the following, except wedge fracture, extramedullary compression, subacute combined degeneration, which may be due to vitamin B12 deficiency or ferric acid deficiency, also disease with a tuberculous mass, and spondylosis. Please choose one. Please vote yes.
It's number C.
Subacute combined degeneration.
Please vote now.
واحدة ليه؟
شالوا بيه.
هم دايروها.
شالوا بيه.
دي مهم.
So the differential diagnosis may be one of the following, except I don't know.
لا دي ايه طبعا؟
33% answer for wedge fracture, 27% answer for subacute combined degeneration, 13% answer for wedge fracture, and 20% answer for subacute combined degeneration, 27% answer Pott's disease, and 33% answer for spondylosis or osteoporosis. So the differential diagnosis could be one of those except one. The patient has paraplegia with a leg. So the answer is the answer, it couldn't be subacute combined degeneration because we have a leg. Okay. The patient has some picture showing microcytic hyperchromic anemia, thrombocytosis, and the typical picture of post-spironectomy thalassemia. During the next. This selective thesis of patients shows the elevation of hemoglobin F. It is 28.1%, but it is during the blood transfusion. This hemoglobin electrophoresis. During the blood transfusion. The patient has elevated indirect bilirubin, increased LDH, normal renal function, blood sugar, and liver enzymes in bilirubin, elevated ferritin, and low viremia for hepatitis C. So, the investigation, radiological investigation of choice right now for our patient, kindly choose one. X-ray dorsal spine, MRI dorsal spine, DEXA scale, POT scan, and CT dorsal spine. So please choose. Most of you answer for MRI dorsal spine, and it is the right diagnosis. When we face in paraplegia, we should do MRI measures. So this is the MRI of our patient. Please remember that we have a level at T6. D1 denoting T1. So concentrate at the T6. Please focus at T6. What's your diagnosis? It is a wedge fracture or extramedullary compression, Potts disease, or spondylosis.
Please vote now. A, B, C, or D.
Most of you answer for extramedullary compression. It is a right answer. Our patient showing intraspinal, epidural, soft tissue lesions in the mid-dorsal spinal canal compressing the spinal cord. The radiological features in a thalassemic patient with neurological symptoms altogether strongly suggestive of extramedullary hematopoiesis compressing the spinal cord. So I would like to ask how many in the room facing a case of spinal cord compression due to extramedullary hematopoiesis in thalassemic patient before. هو كده الفوتنج هيبقى اسهل.
Please vote now.
So it is not uncommon condition because we facing in the same time two patients in the same month. So it is not uncommon like the literature or the reports. 65% begin to see this. I will pass the review. Because of the time. So the management of spinal cord compression due to extramedullary hematopoiesis could be one of the following. Hypertransfusion therapy with a blood target more than 10, high blood target, hemoglobin target, and radiotherapy with low dose localized therapy, surgical decompression, removal of gases, and induction of the fetal hemoglobin, and the above or all the above. So stop.
Please vote now.
فين ستة؟
خليتي المنو بقى
فين ستة؟
كل الطلبات موجودة رقم 6.
يعني
So, most of you answer for all of them. It is right question. Right answer.
خمسة مفيش ستة. خمسة بقى باقي أغلبية
This right. So we have different treatment modality, but the ideal management strategy are still controversial. As the report says that it is a rare condition. Here in Egypt, we see a lot of it. So the next, it is a nice article by an Arabian author in the Pan Arab of Neurosurgery. They reported or studied all the cases which reported from 1954 to 2006. There are more than 100 cases, and study the different treatment modalities and compare with the different modalities. So, some patients receive blood transfusion with a higher hemoglobin target only, and some patients receive radiotherapy only, and some patients referred for surgery only. And the complete remission rate was higher in the surgery. However, the recurrence rate after the 3 modalities is very high. So they recommend that all patients should receive blood transfusion with high hemoglobin target, more than 10, and also, according to the neurological condition, the severity of the condition, and the progression of the condition, either the patient referred for localized radiotherapy or for surgery. And for the high recurrence rate of the condition, serial MRI should be done every 6 months for 2 years, then yearly after 6. Our patient received blood transfusion with target hemoglobin more than 10, and our blood bank helped us for this. And also the patient received oral chelating therapy in form of interferon, and also physiotherapy started. The patient gave symptomatic control and also improved sensation, and his power improved from 0/5 to 3/5. But the decision for surgery was taken for the patient, and patient referred for surgery. And so this slide, the patient regained his complete power after 5 days of surgery. So the take-home message: neurological symptom in a thalassemia patient, especially thalassemia intermediate transfusion independent, should raise high suspicion, and also the management depends on blood transfusion and according to the severity of the condition and the progression. Thank you.
Thank you, Dr. Dyer.
Our patient today is one of my dear patients because I faced with her a certain situation that I didn't expect to face. She was a heavily transfused patient, and she was about to join one of our studies, actually my paper, but she failed to join it because just prior to the beginning of the study, we were faced with one of the exclusion criteria, which was what we're about to see right now in the presentation. My patient is a 6-year-old female patient, the second child of a non-consanguineous marriage. Next, please. She came presenting with pallor of insidious onset, slowly progressive course. So we did her CBC, and hemoglobin level came to be 7.5 grams, with density 65, and reticulocyte count 4.5%. She also has a tinge of jaundice, and her total bilirubin rate was 2, while direct bilirubin was 0.2. What laboratory investigations do you recommend at this point? Okay, another one on the right. You can enjoy yourself still. Patient, pallor, functional hypochromic, attention jaundice. What investigations do you recommend at this point? Our studies, hemoglobin electrophoresis, bone marrow examination, molecular studies for thalassemia, all of the above, but you selectively use STRUs number 1, 2, and 4.
Please go now.
Most of the audience here chose number 1, which are the iron studies. A and C. Next, please. Sorry? Oh, you chose selectively number 1, 2, and 4. Okay. The laboratory investigation showed the electrophoresis. Sorry? I would like to move on forward with the slides because I want to confirm a certain message. Okay. Let's keep the suspense. It's already a bumpy, lengthy ride. The electrophoresis showed the hemoglobin 178.2%, the hemoglobin at 18%, A2 3.8%, and the molecular studies showed homozygous mutation for MY30TA. Now, based on the previous slides, what's the most possible differential diagnosis? Beta thalassemia major, beta thalassemia intermediate, alpha thalassemia, or alpha thalassemia syndromes. Most of the audience chosen beta thalassemia intermediate, and that's correct. Thank you very much. Please. By moving forward to the family history of this patient, we see that the older sister was diagnosed as beta thalassemia intermediate, also with frequent mismatched blood transfusions, and died at the age of 5 years with anemic heart failure due to failure to receive blood at the right moment. However, the younger sister, who is now 1 year and 6 months old, is presented with a hemoglobin level 10 gram per deciliter, is also microcystic hypochromic. So we did her an HbA1c, and hemoglobin F level was 95.7%, hemoglobin A to 4.3% by HbA1c, and the patient till now is never transfused. In our case study, the patient received hydroxyurea, and she was a non-responder after 6 months from taking it, based on the lack of improvement in the frequency of transfusion. The frequency of transfusions increased over 2 years to every 2 weeks. What's the cause of increased need for transfusion in this patient?
Please vote now.
Hypersplenism, actually that's true, because after that we decided for splenectomy. We proceeded for splenectomy and the patient started to receive her vaccination. The patient received her vaccination as a preparation for splenectomy, and she came to us 3 days after that vaccination with fever, up to 40 degrees, seizures, disturbed consciousness, and right-sided hemiplegia. What's the most possible etiology? Post-CNS infection, post-vaccination encephalopathy, post-vaccination microstrokes, congenital thrombophilia, thalassemia cerebrovascular accidents. What's the most possible etiology?
Please vote now.
Well, most of the audience had chosen number 2, post-vaccination encephalopathy. Well, telling the truth here, this patient, after this incident, has been discharged from our hospital according against medical advice. However, she came a year later, and so we revised her investigations, and next time, the answer for this question will be revealed in the upcoming slides. Now, at the time of the incident, the investigations were done showing the CBC hemoglobin was 7 grams per deciliter, the total leukocyte count 25,000, with mild shift to the left, and the CSF analysis was free. Her imaging at that time, she did a CT brain and was free. She also did an MRI brain, which was also free. So, before being discharged against medical advice, the patient received anticonvulsants, physiotherapy, and antibiotics. And then the father went away. He came to us a year later. The patient came with a monoparesis in the right upper limb, weak hand grip, and so we decided to revise all the investigations done. What investigations do you recommend at this point, 1 year later from the incident, coming only with monoparesis? MRA, MRI, transcranial Doppler, thrombophilia screening, hepatitis C virus PCR, all of the above or none of the above. Exactly. Most of the audience chose all of the above, and I agree totally with you. Please. All of the above. So we did an MRA, it was free. We did an MRI, which was bilateral white matter lesions. And we started to
screen her for thrombophilia, showing
دي واحدة عايزين نبص كده بس نبص على المراية حضرتك ورينا
the radiological department, they decided that this and this was a white, according to them, this was white macular lesions. However, they advised to do another one 6 months later. And they did also transcranial Doppler, by the way. Protein S activity showed 76%, protein C activity 63%, antithrombin 3 showed a level 4.9 milligram per deciliter, anticardiolipin F and G were normal, lupus anticoagulants were negative, and hepatitis C virus PCR was qualitative, was negative. So next, please. In this case, this patient with a thalassemia intermediate with a cerebrovascular incident having evidence of congenital thrombophilia, and she came with post-vaccination stroke. Please. Next. This is a multifactorial cerebrovascular incident. Her transcranial Doppler was done and showed in the right MCA an area where there is narrowing, picture suggests narrowing, proximal to which there was increased peak systolic velocity to about 190 centimeters per second. And according to the radiologist, we recommended to repeat this transcranial Doppler also within 6 months again. Patient was started as proceed aspirin. She started aspirin, and according to Dr. Bishleri, she will re-revise her imaging again, especially with the weird neurological improvement without any anticoagulant. And the question will be, should this patient receive anticoagulant for life? Should this patient change her long life term management? Is it hydroxyurea again? Should we start hydroxyurea again? Should we receive blood transfusions every 2 weeks? Except because right now she receives every 1 month. What management could have saved this patient this trouble? Or what management should she receive right now? Thank you.
Sorry, Rosh, I thank you so much, but I have to point out the fact that there is an acquired antithrombin 3 deficiency with thalassemia.
Yes, I know, and yes, I know. This patient with
this might be acquired, not congenital.
Yes,
yes, the protein C deficiency is reported with patient with thalassemia. And yes, and it's also been studied several times that hypercoagulated thalassemia intermediate is a multifactorial condition. However, I think that the post-vaccination instant could be the triggering factor, especially that in the United States, for example, there is a longitudinal study starting from 1990, 199, I think 1990s, in the 90s, till 2010, and they have discovered over 350 cases of post-vaccination strokes. 39.8% of these cases were secondary about from 2 weeks to 6 weeks post-vaccination, especially the flu vaccine.
So, and excuse me, is the patient on an anticoagulant or is she on aspirin or what are we doing?
Right, sorry?
What is the patient taking?
Right now she's receiving Asprocid. Right now.
Just aspirin?
Yes, low dose aspirin, right now. The decision for further anticoagulation is still to be discussed with my senior professors, of course. And I was advised to revise her imaging again, especially with her improving neurological status. Sorry?
هو الحقيقه الكونتروفيرسي هنا ان الليترشر اللي هي ريبورت البوست فاكسينيشن ستروكس كلها كانت بتتكلم عن انفلونزا فاكسين
Flu vaccine, DPT, and hepatitis B vaccine.
والموقف اسمه نيوكوكال مفيش حد ريبورت ان يحصل ستروكس بالشكل ده. لكن يعني هي لها حاجه مالتي فاكتوريال زي الدكتوره رحمه بتقول يعني الفيبر دي مش كونسلنت لان في نفس اللحظه بتحصل فيبر يحصل الكلام ده فهي بتقول بي مالتي فاكتوريال.
Yes, the most common in children was the varicella vaccine, also the flu vaccine 40%, hepatitis B vaccine about 20%, then the DPT vaccine from 2 to 6 weeks post-vaccination. But still there are further studies to confirm that, making a point here that all the patients were already normal patients, that the normal people heading for vaccination, for routine vaccination, not already diseased with other factors. Thank you.
Our patient is a 20-year-old male, Yemeni. He is an obese, single, and with no special habits of medical illness. He presented to us complaining of human discoloration and spotty, especially legs and legs, dating since early childhood. Only on questioning, the patient might exertion. However, he denied any experience, insomnia, dyspnea, cough, and chest pains. He has no history of drug intake or exposure to substances, and his family history was his family history was negative for a similar condition and consanguinity. Okay. On examination, his vital signs were normal, and the patient has mild generalized cyanosis, especially in the tongue, lips, and tailbits, with no clubbing. What could be the cause of this cleavage discoloration? Could it be Algeria, cardiopulmonary disease, chronosis, polycythemia, or all these causes can present with cyanosis?
يعني اتاكد ان الفلور عارف يعني ارجيريا يعني
Okay.
قبل ما يختار
Is Algeria it is the condition occurring with increasing or accidental intake of silver-containing compounds, like intoxication. We didn't ask him specifically for this.
Please vote now.
Yes, all these causes can present with cleavage discoloration, as we didn't inquire about the intake of silver-containing products. We sought medical advice of our consultant and chest and cardiology consultant, and group investigations were requested. In your opinion, what is the most appropriate initial investigation for this patient? Is it echo study, arterial blood gases, chest X-ray, or complete blood count? Both. Okay, yes, arterial blood gases is the most informative initial test for this patient. This is the value of investigation requested, and among which arterial blood gas next, please. Yes. Okay, please. Surprisingly, it was next, please. It was normal with normal partial pressure of oxygen and normal oxygen saturation. Also, the CBC show normal hemoglobin of 15 and normal pressure. All other investigations were normal. So, what could be the diagnosis, please? Up to this level, which could be the diagnosis of the patient. Both Yes, all these causes can cause cyanosis without any abnormality detected by the examination or investigation of the cardiopulmonary. So we are facing patients presenting with low discoloration of his skin, which may be due to cyanosis, and cyanosis is in most cases is due to the presence of high concentration of deoxyhemoglobin. This occurs as a result of cardiorespiratory disease or right to left shunting, and this was excluded by normal examination and investigation. It may occur also if abnormal hemoglobin is present, like low oxygen affinity hemoglobin, or there is an increased concentration of normally present hemoglobin derivative as met or sulfahemoglobin. Also, slate fluid discoloration can occur in other conditions such as Algeria and chronitis. The patient was referred to our clinic for consultation, and high performance liquid chromatography was requested, and it reveals hemoglobin M, next please, at level of 11.8%. So we are facing a patient with methemoglobinemia. It is a condition resulting from the oxidation of iron heme to the ferric state. The ferric state is unable to bind oxygen, and it increases the oxygen affinity of the remaining ferrous hemes. This results in a shift of the oxygen hemoglobin dissociation curve to the left with a reduced amount of oxygen supply to the tissue. Normally, there is constant production of methemoglobin. However, because of the effective reducing mechanism, mainly brought up by the cytochrome B5 reductase, which is NADH dependent, which brought the methemoglobin back to the normal hemoglobin. But there is another enzyme which is TAG dependent methemoglobin reductase. However, in normal condition, it is not working. It works only if there is methylene blue, which is changed into glucomethylene blue, which will be the reducing mechanism. Regarding the etiology of this condition, it may be congenital, where there is globin chain mutation that result in increased formation of methemoglobin, like hemoglobin M, or there is deficiency of methemoglobin reductase as NADPH cytochrome B5 reductase. The acquired or toxic methemoglobinemia occur when normal red blood cells are exposed to substances that oxidize hemoglobin iron, so that the normal reducing mechanisms are overwhelmed. Many products are potentially responsible, including nitrates, which is frequently contaminated drinking water and vegetables and fruits when fertilizers rich in nitrate are used. Nitrite, especially when used as a recreational drug, amyl nitrite inhalation, certain antibiotics like Dapsone, analgesics as phenacetin and acetaminophen, and most important local anesthetics as benzocaine and lidocaine. Congenital causes usually are asymptomatic. However, they may complain of headache and easy fatigability. But cyanosis may present a cosmetic problem to the patient. In acquired hemoglobinemia, the acute impairment in oxygen delivery to the tissue results in symptoms like headache, fatigue, dyspnea, and at a higher level, respiratory depression, seizures, and death may occur. The clinical presentation will mostly depend on the percent of methemoglobin. With less than 10, it is asymptomatic. From 10 to 20, there is cyanosis, and if it is more than 70, it may result in death. When to suspect methemoglobinemia, it should be suspected in clinic if the patient has clinical cyanosis in presence of normal partial pressure of oxygen. Also, on inspecting the blood, it looks chocolate brown as opposed to the dark red violet color of the oxygenated blood. And if we shake the blood with the air, if the cyanosis is due to arterial oxygen desaturation, plus return back to its bright red color. However, in methemoglobinemia, the blood remains dark color. So, what is the most informative test to detect methemoglobin? Is it hemoglobin electrophoresis at pH 7.1, HPLC, pulse oximeter, or CO oximeter? Vote please. Most of the audience choose choice number B, which is HPLC. HPLC will detect hemoglobin M if it is present, but it will not detect the methemoglobin itself. Methemoglobinemia can result from hemoglobin M or toxic causes or enzyme deficiency. So the gold standard, yes, please. The gold standard is co-oximeter for detecting the methemoglobin. Next, please. Methemoglobin has characteristic peaks of absorption at 630 and 502 nanometers, and pulse oximeter, if used, will not detect these wavelengths because it detects only the wavelengths of oxyhemoglobin and reduced hemoglobin, and use the ratio between them to calculate the oxygen saturation. However, co-oximeter can detect up to 128 wavelengths, so it can detect many types of these hemoglobins, which are the hemoglobins which cannot carry oxygen, like oxyhemoglobin, sulfahemoglobin, methemoglobin, in addition to the oxyhemoglobin and reduced hemoglobin. So this should be confirmed by specific method. It is called the Eveline-Mallory method. In this method, if we detect methemoglobin, we add cyanide so that the methemoglobin will change into cyan methemoglobin with change of this characteristic wavelength. So it is a confirmatory method. Yes, next please. Okay, next please. Next. Yes, how to manage patient with methemoglobinemia? If the patient has congenital methemoglobinemia, it is usually asymptomatic and requires no treatment. However, if treatment is needed, methylene blue orally or oral ascorbic acid will ameliorate the condition in case if the deficiency of the reductase system. But if hemoglobin is the cause of this condition, it will not respond to oral methylene blue or ascorbic acid. Next, please. In toxic conditions, emergency treatment should be given by 1 to 2 milligram per kg of intravenous methylene blue as 1% solution. It should be infused rapidly and it can be repeated after 30 minutes if necessary. If you are facing with patient with G6PD deficiency, which of the following is not true? Methylene blue is ineffective. Methylene blue can induce hemolysis. Ascorbic acid is inefficient, or exchange transfusion can be done, which is not true. Okay, let's step forward and to know the answer, please. Okay, this is ascorbic acid is not inefficient, it is efficient in these cases. And next, please. We should give special consideration to patients presenting with methemoglobinemia if they have G6PD deficiency, as mislead group is ineffective and it may precipitate hemolysis. And the possible alternative in this case, please, is vitamin C in moderate doses. Exchange transfusion on hyperbaric oxygen can be given in life-threatening conditions. In moderate doses, it is life-saving in this patient. Special consideration should be given also to induction-induced methemoglobinemia, as cyanogen can be given 300 milligrams orally or intravenously every 6 to 8 hours, and it activates cytochrome B450 and inhibits the conversion of dapsone to its oxidizing metabolite. Our take-home message is that methemoglobinemia should be suspected in patients with cyanosis and normal partial pressure of oxygen. Methemoglobin is best detected by CO oximeter. In patients with G6PD deficiency, mislead group is usually ineffective and may induce hemolysis. Okay, this is our reference. Yes, and this is our
لو في حد بس يعني من بيشتغل في اللاب يعلقنا على البوكس في الاف بي سي اللي طلعنا بيه الاف بي طب دكتوره اسماء حضرتك عرفت لنا يعني ازاي الهيموجلوبين لو الانزيم ديفيشنسي بقى مشخصه ازاي؟ يعني احنا لما هتسمع هو ده يمنع الهيموجلوبين بالظبط ازاي يعني هو في
لا انا عندي حوالي عيال كوري ما في هي البنت دول بس اقل من 1%.
لا ده هو اللي عايز دقيقه هو اللي عايز وعد احنا مش بنعرف
اصلا انا
and while the enzyme deficiency is autosomal recessive. And hemoglobin can be detected by HbA1c and enzyme deficiency can do the enzyme
Now I'm happy to introduce to you prominent and clever hematologist, part of important part of our team, Dr. Ahmed Abdelfatah.
مش هاخد من وقتكم كتير، انا عارف دايما بنيجي تحلوا بينا قبل الغداء على طول. الناس دلوقتي بتكمل تركيزها عشان كده بيسيبونا دايما للاخر. في البدايه انا بشكر دكتور امين بشكرني طبعا كل الصف ودكتور احمد ازاحي بصراحه لان هو اللي ساعدنا في تشخيص الحاله دي. انا جاست كنت عرفت اعمل كاتش اب للحاله من الكلينيك، فان شاء الله الحاله تعجبكم بصراحه، هي انترستنج جدا، فان شاء الله يا رب نبدا.
اما يعرف بس.
اوكي، هو كان ولد 8 شهور في ترايل بوست كونسانجوس مارج بورن اند ليف ات جيزا. قصه الولد بدات عمره 3 مانثs تقريبا. كان البيرنتس بينوف اوكي not in English. The parents know that he's pale and there is rapid heartbeat. Okay. Okay, the next slide please. At the age of 3 months, when we examined him, he was presented to us with severe pallor. There was no clinical evidence of hemolysis at all. Okay, no hepatosplenomegaly. He was tachypneic, tachycardic, and the mother mentioned that there is polyuria by frequent nappy changes. Okay. His sister, this was in the history because we was following his sister before. She was having bicytopenia in the form of anemia and thrombocytopenia. Echo was showing ASD and pulmonary hypertension and insulin-dependent diabetes. Okay, and she died at the age of 10 months during the admission for cardiac catheterization, but we didn't diagnose the case. So, what do you think is the possible diagnosis for our child, not for the right one? Is it could be bone marrow failure, PNH, paroxysmal nocturnal hemoglobinuria, could it be congenital dyserythropoietic anemia, metabolic or nutritional anemia, or could it be Pierce-Sumar syndrome or myelodysplastic syndrome?
Please vote now.
I'm asking now about the case, not his sister who was dying. Okay. Okay, most of you choose congenital erythropoietic anemia. Okay, the next slide. The right answer it was the fourth one. It's metabolic or nutritional anemia. We are going to explain next one. Okay, please the next slide. Okay, this was the lab finding for our child. It showed normocytic, normochromic anemia. His hemoglobin was 5.5. Some of the CBCs show also thrombocytopenia, like his sister exactly. It means we have bicytopenia, anemia and thrombocytopenia. His iron profile at the first time of his presentation, the serum iron was 15, and the retics was 1.9, but as I said before, there was no clinical evidence of hemolysis or lab evidence of hemolysis. And it was something strange that his blood sugar was 300. We say that it may be something related to stress or hemolysis. Okay, next slide please. Later on, after we gave him blood, we did the investigation in order to re-evaluate the case. His hemoglobin was 7. It was also normocytic normochromic anemia. The retics was 1.5. The platelet mild thrombocytopenia. His serum ferritin was 760. Actually, this had been done after many times of blood transfusion. During his follow-up with us within 2 months, he was transfused every 15 days. Okay? The blood sugar also was the same, but kidney, liver, and function was normal. Okay, please the next slide. So, what do you think? What the other investigation you may ask for? Would you ask for triglyceride I5-prenogen? Okay, metabolic screening, echo, bone marrow aspirate biopsy, CD55, CD59, or oximetry?
Please vote.
Okay, most of you choose metabolic screening. This is expected, but actually the right answer is the geometry, and we are going to say why. Okay, next slide please. Okay. Next slide. Okay, this is the result of the investigation of the patient. The bone marrow aspirate biopsy actually showed the breast erythropoiesis and mild reduced thrombopoiesis. The chest X-ray showed cardiomegaly. Okay. The echo showed ASD and pulmonary hypertension, exactly like his sister who died without diagnosis. The baby abdominal ultrasound was normal. The hemolytic profile for sure was normal. We did try glyceride and fibrinogen to seclude HLH, and it was normal. His blood sugar was 350. Okay, the next slide, please. During this follow-up, up to now we didn't diagnose him. His blood transfusion was every 15 days. He began to follow at the endocrinology, and they started to give him insulin, and they diagnosed him as insulin-dependent diabetes. Okay, and we refer him to the cardiology and said it needs a repair for the AST. The next slide. So now to sum up what we said, we have anemia and thrombocytopenia. We have insulin-dependent diabetes, we have congenital heart disease, his sister was the same, and he is blood transfusion dependent. It's a syndrome for sure, but what do you think it could be? The first choice is thiamine-responsive megaloblastic anemia. The second is this is syndrome is diabetes insipidus, diabetes mellitus, optic atrophy, deafness, or it's Wolfram syndrome, it's insulin-dependent diabetes, deafness, and optic atrophy. It's MDS or some mitochondrial disease. I know that this is actually it's very rare even in the USA, but it's interesting.
Now please vote.
So can you vote for the choice for the diagnosis? I know that it was really difficult for even in the sub round, but it was diagnosed by Dr. Ahmed at that day. باختصار optic atrophy. لا the patient no we didn't do but clinically there is evidence of deafness for the patient.
كان عندنا عيان
okay, most of you, I just want to congratulate the 32% who chose the choice number 1. It's called thiamine responsive megaloblastic anemia. Okay, this was the diagnosis of the patient. Please, the next slide. Yes. So the diagnosis of thiamine responsive megaloblastic anemia, it required the following: megaloblastic anemia, sensory neural hearing loss, diabetes mellitus, congenital heart disease, and our patient had all of these criteria finding in him. Okay, we found megaloblastic anemia. I know that MCV is not so high, but this can be explained by that he was in iron deficiency anemia. That's why the MCV was between 75 to 80. That's why it's not chosen as finding the megaloblastic anemia. And he has sensory neural hearing loss. He is diabetic, and we have congenital heart disease. Okay. Actually, it's an autosomal recessive disease, and the anemia is corrected with just to give vitamin B1. That is his treatment. We are going to show you even the response when we started with him thiamine beta 1. Okay, the next slide. We started to give him vitamin B1 on 25 milligram per day. Actually, now he is transfusion dependent for 2 months. We didn't give him blood. Before he was given blood every 15 days. And what we find also that we have now better control on the insulin dependent diabetes. His blood sugar is better. He requires less doses of insulin. And this is actually what we have with our patient. So it's called thiamine responsive megaloblastic anemia. Thank you.
Thank you very much, Dr. Ahmed, for this very nice presentation and interesting case. Now we conclude our session. Any questions? Any questions?
The bone marrow didn't show any changes of megaloblastic anemia.
iron deficiency.
Actually, bone marrow, it should have been done with an iron stain, but at that time, his sister was diagnosed as pure red cell aplasia. So it was not a routine to order, like an adult, the bone marrow with iron stain. We have to require it from the clinical pathologist. So it was not done by iron stain to see the usual cellular blast. And the bone marrow, interestingly, as you have said, didn't show megaloblastic changes. But the remarkable response with the thiamine, he became transfusion independent, and also the diabetes started to improve, concluded the diagnosis.
I would like to say in the adult clinic or our department, we face a case of Wolfram syndrome with anemia, and he do genetic studies, and he discovered to be Wolfram syndrome, and he has anemia and thrombocytopenia also. So the patient didn't do any.
But the Wolfram syndrome will not improve so remarkably with thiamine, and it does not have extreme cardiac effects like thiamine responsive megaloblastic anemia.
But I think the patient needs genetic studies.
Yes, it needs to be
Classical syndrome. Then once you give the treatment and improvement, this is diagnostic. Therapeutic test. بالظبط. وبعدين كل الكرايتيريا of the syndrome is different. ده في واحد.
Unlimited in pediatrics. They include piercing marrow syndrome, they include thiamine responsive megaloblastic anemia. They also include some cases of polyglandular autoimmune disease which have diabetes, and they have also pernicious anemia. But the important thing that the patient presented not with macrocytic anemia. She presented with almocytic anemia because of the sheer iron deficiency. So it has bimorphic population, one microcytic and other macrocytic. Thank you.
Well, thank you all for being here and your attention and your existence in our conference, which is a yearly conference. And the remarks which you want to find out and send it to the authorities is number one, we have to, the government should stress on prevention of thalassemia in Egypt. Number one, through awareness, through the mass media. Number two, by a real pre-marital screening. Number three, prenatal diagnosis for high-risk pregnancies, and as well, it should be not only doing screening for thalassemia and prevention, we should have the proper treatment of all patients. Because most of our patients, especially in the global race, did not find blood in these areas, especially in Upper Egypt and other areas, which is far from the cities. Most of the patients cannot find even the blood transfusion. So we have to do prevention of thalassemia, real prevention of thalassemia on one hand, and give the proper treatment of thalassemia on the other hand. حاجة دلوقتي احنا كنا بنطالب بيها انهم يدرسوا الثلاسيميا as a model of genetic disease في المدارس في العلوم. في العلوم بياخدوا اللي هو الديزيزز اللي هي ريسيسيف اللي هي متنحية والدومينانت والسائلة والحاجات دي. حتى الثلاسيميا كموديل بحيث ان الطالب يطلع من الثانوي او من الاعدادي عارف يعني ايه ثلاسيميا ويبقى اكيد ان هو يعمل سكريننج. اذا ما كناش نعرف الناس الجنرال بوبيليشن يعني ايه ثلاسيميا ولا حد ايه ما خاطر ان هو يتجوز واحده بتستحمل المرض زيه لو كان هو بيحمل المرض مفيش حد باكين انه يعمل بري ماريتال دايجنوزس اوف ثلاسيميا. زي ما انتوا عارفين كل واحد بيضرب شهاده زي ما الحكومه عارفه، وايفن الحكومه مش حاطه الثلاسيميا من ضمن السكريننج تيست اللي لازم نعملها علشان نمنع انتشار مرض الامراض الوراثيه اللي مصر الكيرف بتاعها بيعلى لفوق، والناس كلها اللي هي عندها this disease by preventive screening and prevention regimen and strategies قدروا انهم يمنعوا الثلاسيميا وولاده حد جديد. زي ما سمعتوا مننا 100 مره ان اكثر من 1000 طفل بيتولد وكل 1.5 مليون بيتولدوا. ما شاء الله عدد اللي بيتولدوا كل سنه بقوا اكثر من 2 مليون. فيعني احنا عدد اكثر من 1000 مليون. فدي الحاجات اللي we are going to stress and we are going to present to the Ministry of Health. وده بعد ما تقولكم كلكم تاني لحد ليه اي اقتراح اخر.
PCR for hepatitis for transfused blood must be.
الحاجه الثانيه اللي مهمه زي ما الاستاذه الدكتوره وسام الرحمن قالت ان زي ما قلت ان لازم نجيب بروبر تريتمنت للثلاسيميا. نوفر لهم العلاج المظبوط ونديهم الدم الامن. لازم تقولي في تيست اسمه نت المفروض ان هو بيديتكت ايفن الدي ان اي بتاع الهيباتيتس سي في البلاد. They should do though it is expensive. بس عايزه اقول ان لو بصينا treatment of hepatitis C it is much more expensive. في نفس الوقت ندي حياه سليمه حاجه من المرض اللي اولى. وكل سنه وانتم طيبين وان شاء الله باذن الله ننتقل. وتفضلوا كلكم في